Welcome everyone to our virtual symposium for patients on inherited kidney cancer, living with kidney cancer risk and treatment updates. My name is Kristen Shannon and I am a genetic counselor and the director of the Cancer Genetics Program at Mass General Hospital. And I'm so grateful that you've decided to join us tonight to talk about this topic. Just a couple of housekeeping things at first. So you are in listen only mode right now, and if you want to ask a question, you should use the Q&A feature, which is at the bottom of your screen. The chat function is disabled, and if you ask a question through the Q&A feature, your answers can be anonymous, or I'm sorry, your questions can be anonymous, and only the panelists and the host will see them. The panelists will answer the questions after their discussion, and we'll monitor the questions as they come in. Dr. Iliopoulos' talk will be second in the program, and he will answer questions at the end of his talk. Dr. Iliopoulos' lecture will be recorded. The patient portion of the symposium tonight will not be recorded. I want to thank Alicia Estrella and the Estrella Foundation for their generous donation for this hosting this webinar, and I'm going to hand it over to Alicia for a welcome. Thank you, Alicia.
Just going to share my screen with you. Thank you everybody for joining us tonight for the webinar. It is our third webinar to update families and caregivers on things going on in the world of kidney cancer. Although this is our third webinar, it is actually our 20th anniversary of fundraising and raising awareness for kidney cancer research and families. We have been donating research grants and our helping hand grants for these 20 years, and we encourage you to reach out to our website to see some of the fun events that we have on a year-long basis for raising the funds for research. We also welcome anyone who's interested in doing a fundraising event. We're happy to help you and help donate money to fund kidney cancer research. I'd like to thank the patients and Dr. Iliopoulos for their time and expertise and experience tonight, and I hope everybody enjoys the information. Thank you very much.
He is the clinical director of the Von-Hippel Lindau Disease in the Familial Renal Cell Cancer Program at Mass General. And Dr. Iliopoulos is going to share some updates about screening and treatment for renal cell cancer. So Dr. Iliopoulos, take it away. Thank you.
Thanks, Kristen. I want to say that it's a lot of times for us physicians that they go to conferences and we learn a few things, but I want to say that the last hour has been quite eye-opening for me, and I want to thank both Sari and Ashley. I heard Sari speaking before, and some of the things that he said are familiar, but even have heard him before, every time that he speaks, and I mean there is another aspect of the disease and the interaction that we have that's highlighted, and it was the first time that Ashley I heard Ashley voicing so many things about the disease, and I want to kind of reassure both of them that despite the fact that they think that I may know these things, these are kind of practice changing, essentially recommendations and advice that they have given us tonight, given me tonight. So thank you both very much. I'll try to be brief, and I will try to be a little bit more general about it and highlight things that they're new. So I'll give a little bit of a short description of hereditary renal cell carcinomas. Then I will talk a little bit about what type of surveillance we have. And most of the time I'll talk, or actually a significant part of the time, I'm going to talk about treatments for renal cell carcinomas, because we have a changing, shifting, tectonically landscape, as you heard from Shari and Elsie, in the ways that we can treat now at least one localized disease, and definitely another second, more progressive disease. And if we have time at the end, which probably we're not going to have, I was going to say 2 words about the research that we're doing, hereditary renal cell carcinomas. So I'm not going to list everything. We will talk today about 3 major kind of diseases, lump them together, 4. One of them is VHL, because it's quite prevalent disease. And I group them. The second disease is the hereditary paraganglioma disease. The third disease is Burr-Hogg-Dubé, and hereditary leiomyoma and renal cell carcinoma disease. I group them this way here in this slide, because one of the things that it's important, I'm sure the patients know about it, is that the histology of the disease corresponds a little bit to the germline mutation. So for us as healthcare providers, it's important to know, even the history of the disease, what type of renal cell carcinoma did your mom, dad, or uncle had. And you're going to hear from the genetic counselors, or me, or anybody else who's taking the history of the question, it was kidney cancer. Do you know if it was clear cell or it was papillary? It's very important information for us to hear, because it can direct our suspicion towards different genes. So let's go to the description of the diseases. VHL disease. The VHL patients are more than familiar with this description. The non-VHL patients, they may recognize some of the similarities here with their own potential risks. The most common tumor in the VHL disease, the hemangioblastoma. Historically, we focused on the renal cell carcinoma, but we know now that the most prevalent tumor is the hemangioblastoma, and a lot of morbidity comes from the hemangioblastoma, because the surgery there is definitely much more subtle and intricate than operated in the kidney. So VHL patients may have hemangioblastomas, may have renal cell carcinomas, may have pheochromocytomas, and the pheochromocytoma is a common theme between VHL, succinate families, and hereditary leiomyomatosis disease. It appears that a lot of the things that disturb the cell in the VHL overlap, and they're common with other things that disturb the cell through a different mechanism in other hereditary diseases. And of course, that explains this commonality, why different people with different mutations end up with renal cell carcinoma. VHL patients also may have pancreatic islet cell tumors. We call them PNETs, for pancreatic neuroendocrine tumors. They are not having an increased risk for adenocarcinoma. This is very important. So cancer of the pancreas is not a PNET. And I was shocked, actually, to even realize how this is confusing sometimes for people, when a long-term patient of mine the other day said in the clinic, well, all my relatives say you should ask him, is it really possible that you live longer with pancreatic tumors that you are having? And I got, kind of electrified my chair, and I said, wow, my goodness, you don't have pancreatic cancer. You have a neuroendocrine tumor of the cancer, which is a totally different thing. And VHL patients also have this kind of mixed bag, mixed things. They look like a bag that have inside grapes, and they're serous adenomas. These serous adenomas can develop in the middle ear. They can develop next to the uterus or on the top of the epididymis. So this is VHL disease, and then another group of diseases are the ones in which, in the personal history of the patient or the family history of the patient, renal cell carcinoma is connected to melanoma, and this can be people that they have germline mutations in the gene that's called BAP1 or in a gene that's called MITF. In the case of the MITF, the combination is straightforward and it's kept quite dry. It's renal cell cancer and melanoma of the skin. And the renal cell cancer is not actually very prevalent. So it's about 5 to 10% of the people that they have this mutation. In the BAP, things are a little bit more complex. The melanoma can not only develop in the skin, but also can develop in the eye. And that's why the follow-up of these patients is a little bit different. We do very good derm exams, but we also look in the eye. And then these patients develop another kind of cryptic tumor, which is called mesothelioma. And mesothelium is the internal lining of the chest and the abdomen, kind of a very silky, soft tissue that wraps around the lungs or wraps around the intestine. And these tumors, this silky lining can sometimes develop tumors that are called mesotheliomas. What we came to appreciate a lot as prevalent disease, and we're not aware of this about 10 years ago, so this is more recent development compared with the VHL or other diseases, is this family of mutations that they give the diseases that's called hereditary pheochromocytoma and paraganglioma. And these are some enzymes in the cell that have to do with mitochondrial functions. There are 5 family members, A, B, C, D, and F2, AF2, this stands for assembly factor. And when people have these mutations, they called succinate dehydrogenase genes, they of course develop renal cell carcinoma, that's why we're talking about today, but they also develop more prominently pheochromocytomas or paragangliomas. Pheochromocytomas are tumors of the adrenal glands. The adrenal glands are some small tumors in the top of the kidney, like a small hood or hat in the top of the kidney, and they release adrenaline. So these are kind of the adrenal responses of the body, the centers, and the same type of tumor may develop also out of these small hats in the top of the kidney, may develop in other areas of the body that, by development, we have tissue that look like the adrenal tissue. It's kind of nervous tissue, and it's called paraganglioma. They also have gastrointestinal stromal tumors, GIST. It shows a lot in the pediatric population. That's why we need to check kids when they're young, and pituitary adenomas. Again, the gastrointestinal stromal tumor is tumors that they can show up in the stomach or the intestines, and is not the classic cancer of the intestinal tract or colorectal cancer or cancer of the stomach. They're tumors that they behave in a kind of much more milder way than the classic adenocarcinomas. So the type of the disease, the combination of the tumors that develop in people that they have these germline mutations is different depending on which one of the subunits, which family member is mutated, and also the severity of the disease is different. Without having 100% certainty, the people they have a mutation in the member B, they fare a little bit more aggressively than the D, the C fares a little bit better than the D, and the A even probably the best of all of them. The other disease that we see a lot in the clinic, and I'm sure there are patients or healthcare providers that they deal with this disease, is the HLRCC, hereditary leiomyomatosis and renal cell carcinoma. And it takes its name from this, you can see reddish lesions here that people have in the skin. They can be sometimes very sparse here and there. Sometimes they can be very confluent. They're a little bit bumpy. They're pink, and they can be sensitive. Most of the times they're not, but sometimes they can be sensitive to cold. They can be sensitive to touch if they're very sensitive. And these are skin leiomyomas. Non-cancer of the skin. They are not aggressive things. They're just kind of an indicator, a marker that somebody may have the disease. The people with the HLRCC, they can have these skin lesions. They can have fibroids, the women in the uterus. They give them a lot of bleeding a lot of times, and they have a family history of very heavy fibroid history, and a lot of times bleeding or hysterectomies because of the bleeding the fibroids are causing. They develop renal cancer. It's not clear how often they develop the kidney cancer. It's between 5 and 40%, which I know it's a big difference. It's not like the MITF that they said 5 to 10%, but sometimes because there are smaller number of these patients, according to every center and publication, the percentages can vary significantly, and they develop again the paraganglioma and the pheochromocytoma. See, this paraganglioma, pheochromocytoma is a common theme between VHL, between succinate dehydrogenase families and HLRCC, and that's why any patient anywhere that has paraganglioma or pheochromocytoma at any point without other things that they need to be present in the family or personal history to indicate this is suspicious should nevertheless test it for this panel of genes that they may have germline mutations. Last disease are the fibrofolliculomas. The Burke-Hogg-Debye disease. Again, the Burke-Hogg-Debye disease, the only dangerous, so to speak, disease that they may develop is renal cell carcinoma. They also have some lung cysts, and they have spontaneous pneumothoraces. Pneumothorax is when your lung pops. These pneumothoraces are not life-threatening. They can be scary because they can cause acute shortness of breath and sometimes chest pain, but they are not life-threatening. And they have, again, these skin bumps that although in the pictures that I show here, they may appear similar, they're quite different from the leiomyomas. They're not reddish. They're more kind of protruding. They're very characteristic, because one, you have seen a couple of them. Remember that I asked what that the healthcare providers a lot of times ask, what is the histology of your cancer, or the histology of the family member that had the cancer, and the answer was, well, if it's VHL, it's a clear cell. If it's HLRCC, it's papillary cell. Burke-Hogg-Debye can do anything. As a matter of fact, sometimes all these different histologies of kidney cancer are mixed together, and the pathologist will send a report that says, you do have kidney cancer. This is kidney cancer, but really, I can't tell you exactly what type of kidney cancer this is. And in this case, Lauren heard me a lot of times say, well, I know there is Burke-Hogg-Debye disease. So how do we care before these cancers develop, and how we care about keeping an eye and do surveillance and for these diseases? First of all, we have a low threshold of suspicion, and then that means that we refer people for testing among healthcare providers, and the criteria for testing people are here. I mean, the reasonable and kind of common sense criteria is that if you are a member of family member of some family that has the hereditary kidney disease, you need to be tested, or if you have a kidney cancer associated with another tip, another lesion that provides a tip, like a hemangioblastoma, a leiomyoma, a pheochromocytoma, it starts giving you a tip and a hint that this may be hereditary. But one of the things that I wanted to actually emphasize here is that any patient who has a pheochromocytoma and paraganglioma, or any patient who has a hemangioblastoma, even a single hemangioblastoma or a single pheochromocytoma, needs to be tested, because the possibility of hiding a germline mutation is high. And of course, any patient that has a spontaneous pneumothorax, spontaneous means non-traumatic, because you can have your lung pop if you're in a car accident, or if you fall all of a sudden out of a mistake on a sharp knife. You can have a pneumothorax, but the spontaneous ones is the ones that they happen while you're watching TV most of the time. So these spontaneous pneumothoraxes are suspicious, and people need to be tested for Burkitt disease. So when do we test them, and what type of surveillance we do? This comes very often. I have Burkitt. When do I test my kids? Well, when we want to test the kids, when we're going to do something different. That means that when clinically we're going to start the surveillance. If we start the surveillance of somebody when they're 20 years old, I don't think it helps a lot to know that we need to start and they have the disease or the mutation when they're 6 years old. So for VHL, we start at birth, and the reason is that pheochromocytomas and hemangioblastomas of the retina can appear very early. This is the genetic testing. This is not the surveillance. The surveillance specifically for renal cell carcinoma starts around 15 years old. For hemangioblastomas starts quite earlier, around 10 or 12 years old. The people that we suspect that they may have folliculin, folliculin is the gene that's connected with the Burkitt. We want to test them when they're, kind of between 12 or 15 years old. And the people that they have these BAP1, succinate, MITF mutations, we want to test them early, because the risk of developing the disease, and therefore the surveillance starts increasing when they're 10 years old. We have specific protocols for following these patients, and for the sake of time, I'm going to skip them. And here are some points of concern that a lot of times patients ask about the surveillance protocol. One of these concerns is it okay to take all this dye for the MRIs continuously? I mean, it's going to deposit my brain, my skin, and it's going to harm my my life in the long term, because there's a lot of MRIs. Well, first of all, I want to say we don't do CAT scans, we do MRIs, because we don't radiate the patient. And the new contrast agents, the chemical agents for the MRIs, which are not linear like the old ones, but they're macrocyclic. That means that they're kind of in a circle. They do not deposit in the skin and in other organs, and therefore they're considered quite safe, and they can be used for long term. What's happening with the pregnancy in these diseases? Do the pregnancy accelerate the tumors in VHL or general hereditary renal cell carcinomas? The data are conflicting. My vote, and I leave it for another discussion, would be that I think that most probably not. So I just want to make sure that my patients have an MRI before they decide to become pregnant, to make sure there isn't any tumor there that we have to take care of, and right after the end of the pregnancy. Can they have an MRI while they're pregnant? So they can have an MRI while they're pregnant if no contrast in use at any time. They can have an MRI when they're pregnant with contrast, although we usually do it without contrast during the second, the third trimester. How about breastfeeding an MRI? Because now patients have a baby. I tell them, okay, congratulations, let's have an MRI, and the question is on breastfeeding. In theory, for all these reasons that you can read here, it is absolutely fine to have a contrast for MRI and breastfeed. Out of an incredible abundance of caution, the simplest thing to do is bank milk and skip a 48 hours of milk collection after the MRI, and then you can go back. It's minimal contrast that goes to the milk, and even more minimal contrast that potentially can be absorbed of the gut of a baby. So how do we treat all these renal cell carcinomas? So there are two types of players. There are the good players and the bad players. Good players are the ones that they grow very slowly. And so even if we see them at the beginning, we have a lot of time until we act when we act. And there are the more aggressive players. And I don't mean to alarm you and kind of being all of them in the same box. The SDH, the BAP1, and the MITF are, I would say, intermediate players. Probably I'm going to change the slide. The one which we are a little bit apprehensive about is the patients that they have the HLRCC and they have this fumarate hydratase mutation. These tumors, again, they don't develop often. So the majority of the patients that have HLRCC will not develop renal cell carcinoma. But when they develop, they can go very fast from 0 miles per hour to 100 miles per hour. So the idea here is we see them, we take them out. As you've heard before and you have previous experience, the landscape shifted a lot about the treatment of renal cell carcinoma. We now know that any renal cancer that's less than 3 centimeters, the VHL patients and in the Bert-Hogg-Vivet patients is an innocuous one, and it does not have to be taken out. And if it has to be taken out, it has to be taken out the tumor itself and not the kidney. But the tectonic change in the landscape appeared in 2021 when the belzutifan, this oral medication, came on stage and changed the whole prognosis and the treatment of the VHL. So we apply for VHL, and we do not know if this one applies for the other diseases. People test right now if it applies to other hereditary tumors, and my suspicion is that for several of them that they have a signature very similar to VHL, like the ones that they are succinate dehydrogenase or fumarate hydratase, I suspect that belzutifan will be active too. But so far, we know more information that we know is coming from the VHL. When we have VHL in our body, we don't have this bad player, which is called HIF. And when we're losing the VHL, the HIF goes rogue. And the HIF, in order to turn rogue in the cells and act like an oncogene and make the cell cancer cell, has to partner with this partner here, that's called ARNT. And what this medication is doing is a small molecule that we take through the mouth and goes and essentially squeezes itself between these two partners and breaks the relation apart. And now individually, all these proteins, if they're not able to bind together, they cannot act in the cell. So essentially it eliminates this major culprit of the cancerous cells, which is the HIF. This medication is taken on a daily basis, continuously, 120 milligrams, and as you heard, it's very, very effective. That was the seminal publication that we sent New England Journal of Medicine 2 years ago that put it in the market and got FDA approval. And this is how it looks now. This is the time that we apply the medication. This is the growth of individual tumors in many patients for years before they start taking the medication. After they start taking the medication, you see that they decline here, and some of them, they have a complete response, meaning disappearance of the tumor. So in this study, 61 patients were enrolled, and because of time limitations, I'm not going to go very analytically through this, but this is the important table that I think that we need to focus on. So in the tumors, as you know, they're treated with the medication, we have a complete response. Complete response is when the tumor completely disappears. Partial response is when the tumor shrinks by 30%. That means that it is 70% of what was before the treatment, and the combination of complete response and partial response is called objective response. Like, did we manage to shrink tumors? And in the case of renal cell carcinoma, 64% of the patients had a response in the kidney, with 7% having complete responses. In the case of hemangioblastoma, 44% of the patients have a response, with 8% complete responses. And in the pancreatic neuroendocrine tumors, 91% they had a response with a 32% complete responses. Now, of course, as you can see, the numbers here is 61, 50, and they drop to 22. And now we have more studies that we expand in these cohorts of patients, these groups with hemangioblastoma and pancreatic neuroendocrine tumors, to make sure that these percentages is not a false result of the small representation in the study. But it's suffice to say that this is the response that we observed within 3 years, and the cutoff line is April of 2022, and patients are still treated with this. This is a graph that shows how patients have been treated. This is renal carcinoma patients, and this is the 4 complete responses. And the dots in this graph, every line is individual patient. The dots are surgeries, any type of surgery, brain surgery, kidney surgery. And the gray area is before they start belzutifan, and the green lines is when the patient started having belzutifan. And as you can see, all these dots that indicate the operations do not happen when the patient starts having the belzutifan, and that's why it brings a huge change in their personal life. This is an MRI of the first patient, actually, that I treated with belzutifan in Mass General Hospital, a remarkable individual that I personally, love and admire. And this individual, this patient, came with a big tumor in their brain, and within 6 weeks, the tumor shrunk significantly. Within 12 weeks, the tumor was half of the one that was before. This is an amazing rapidity of response. And a year now and several months later, this patient continues to respond to the belzutifan and this remarkable findings. It's very well tolerated medication. The only really side effect, which is not side effect, is an on-target effect that is anemia. It is predicted that the red cells are going to decrease in the body because HIF is the protein that drives the red cells. But again, people have been able to tolerate this anemia very well. In some cases, we give them erythropoietin, kind of a endocrine booster for the red blood cells, and they respond to this very well. I think, and I want to say that now there are additional trials that are open. There is an international trial that we have open at the MGH that tests metastatic pheochromocytomas and paragangliomas in neuroendocrine tumors that either locally advanced or they're localized, completely localized, to see if we can completely avoid surgeries. And a study that we designed in the MGH that we have patients with RCCs and hemangioblastomas that seeks to find out, to answer questions, what's the best use of this weapon we have? Should we give it all the time? Should we give it intermittently? Can the patients take breaks? Does it matter if we increase or we decrease the dose for in case they have side effects, and so on and so forth? And the other new combination in our kind of weapons against renal cell carcinoma applies to the fumarate hydratase disease, to the HLRCC. This is not for localized tumors because, as I said, once we see the localized tumors, we take them out. But in case that these tumors escape the kidney, become sporadic, then we can treat them with this combination of erlotinib and bevacizumab, an oral medication, and an IV medication. These tumors were almost untreatable before, and now we see great responses with these combinations. I think I'm going to stop here. I'm not going to talk about the research that we're doing in the lab because the time is getting close to the end, so I can have a time to answer any questions. Okay, let's see.
Thanks so much, Othon. There's one question that came in, and it's more of it's taking a patient lens. So the question is, when a patient is considering participating in a clinical trial,
yes,
like the ones you were describing, is there anything specific they should consider?
It's a very interesting question. I think that they should consider all the alternatives. It's a very simple thing. They should participate in the trial. The trial is a choice, and they should ask for all the choices that they have. For example, can they go to surgery? should they take the belzutifan? Is it possible? I mean, is it better choice, I mean, to have the surgery? Because there are ups and downs in every choice that they're making. Then, for example, I am not sure how we treat very different patients, and I skipped a slide with different scenarios with belzutifan. Like if you're somebody who has multiple tumors or had 2 craniotomies and 3 craniotomies before, and you're sick and tired of surgery, and your kidneys are kind of hanging there in the insufficiency area, and if you have one more surgery, you will develop chronic kidney failure, I would say, oh, let's not have it. I'll go with belzutifan. But you have a 28 years old man or a woman, woman in particular, because we don't know what the effect in the fertility is, that they have one spot in the kidney, which is 2.5 centimeters. Should I commit them to belzutifan for the next 5 years, or should I send them to the surgeon? My preference would be to send them to the surgeon. So one thing is, examine all your options. What do we know from any modality of treatment? We don't know about surgery, radiation, ablation, and oral treatment with a medication. The second one, in case that you decide to go to the clinical trial, the questions that we want to know is this new medication, the clinical trial that I'm trying, what are the side effects? How long is going to take in the clinical trial? Will I be able to stop it if I feel uncomfortable? How soon I should see the results? I don't know. I mean, I don't believe in medicine that's like 7-Eleven or you know, Starbucks or supermarket. I don't think that you say to the patient, this is the different you know, pastries that we have, which one you want to choose. In the end of the day, I would ask my doctor, what do you think? You know, what's your recommendation? What should I do? I usually give the patients all the options, and then I say, if you were my sister, my daughter, my mother, my brother, this is what I would choose. And sometimes I explain that it's a gray area, but I think that a very good in-depth discussion about the pros and cons between we make a decision should be done. It's not enough to say to the patient, oh, here, you have a new hemangioblastoma, and I think you need to take belzutifan.
Thank you so much, Dr. Iliopoulos, for that answer and the amazing talk. Thank you so much. We are running up right against the hour of 7 o'clock. I want to again thank our 2 patient panelists. Thank you so much for sharing your experiences. Thank you, Dr. Iliopoulos, for that wonderful talk. And again, a huge shout out to the Estrella Foundation for sponsoring this event. Please, for all the participants, you will be getting a survey in an email shortly after this program. So please fill it out, give us any feedback, and we hope that we will be able to do this again for you next year. So thank you so much. Go ahead, Othon.
No, I was going to say I want to thank you again for having, but I want to extend in particular thanks to Shari and Ashley. I leave this discussion because I didn't learn anything from myself, but I leave this discussion I think quite much more with eyes open to the need of the patients that I had before.
Thank you so much, everyone. This is the end of our program.